David, are there any hot new ideas drug-wise in squamous?
Absolutely. I think obviously we've talked a lot about immunotherapy alone or potentially in combination, and that will remain, I think, the most exciting potential area for squamous patients. But, beyond that, I think we back up a little bit to some of the seminal work that Peter Hammerman, when he was at Dana-Farber, and Paul Paik at Memorial Sloan Kettering had published on looking at the squamous genome. We talked about how we don't see targetable mutations in squamous, and I think that's something we're trying to crack at. We see that squamous patients can have PIK3CA mutations, PTEN loss, FGFR mutations, and so now we move forward and we look at the lung map study, looking at trying to study squamous patients' tumors, and then depending on what we find, putting them on a sub-study arm. That is, if we find an FGFR mutation, we're putting them on treatment with an FGFR inhibitor, looking at patients with CDK inhibitors, looking at patients with PIK3CA mutations getting specific drugs. And so I think ultimately we're going to try to figure out, are these mutations that we're seeing, are they druggable? And does drugging them potentially alter the course of these tumors, or is it just that these are not a strong enough driver of disease?
And I think having said that, the lung map trial, if our audience has the ability to accrue to it, that's an important trial for us to do. Well, I want to thank you guys. This has been extremely informative. Before we get to the end of this discussion, I'd like to get your final thoughts. I'll start with you, Tracey.
Yeah, so I think we've got a lot of new hope for this patient population, but we need to remember that a lot of these agents won't work for people. And I used to be a big erlotinib before anyone died of their non-small cell lung cancer because it had that small survival benefit. And I don't think that way anymore, in part because there's so many other options that I'm not tolerating these drugs that don't work well. And also I think it gets in the way of the important work that all of our patients have to do, and that is facing the fact that they have a terminal illness. So it's wonderful when these drugs work, but we need to remember to support our patients when they don't.
David?
I think that I hope for our squamous cell patients we learn lessons from what we've done in non-squamous. That is, we need to get adequate biopsies so that we can do these tests, so that we can check PD-L1, so we can potentially enroll them on lung map. And so for all of our squamous cell patients, I hope that we're getting adequate biopsies so we can inform our treatment decisions.
Ed?
I mean, what a cool time to be in lung cancer. And that's not something that when we were in fellowship that was necessarily two words that followed in the same sentence.
We weren't considered cool in fellowship.
No.
We're still considered cool.
No, I disagree, Jared. This is a cool field. You have people now who are actively seeking, want to be thoracic oncologists now because of all this stuff that's happening. I mean, EGFR mutations, ALK translocations, ROS1, now PD-L1. I mean, it's phenomenal stuff. And so I think, again, to the community oncologists out there, and I deal with many of them in our system, you deal with them now, you have to test for biomarkers. Right. Please test for biomarkers.
Jared?
So I think historically in squamous lung cancer, every time we had an advance that we thought was it turned out to be incremental. And I think many who've been around this field for some time are afraid we're going to do the same here. And I'd like to sound a note of hope and a prediction that I don't think that the checkpoint inhibitors are going to be a one-off incremental advance. I think they're the beginnings of something much larger that legitimately is going to translate to some cure or something cure-like durable control in a larger percentage of patients than even our greatest optimists are imagining right now.
Well, I'm the senior member of this panel, and I will tell you that I trained at a time in lung cancer where we argued whether or not lung cancer could be treated at all. And that wasn't that long ago. So this has been wonderful. I want to thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.